So I appreciate the opportunity today to present the preliminary safety and efficacy results of IPI 145 in patients with chronic lymphocytic leukemia on the behalf of my co-investigators who are listed on this slide. So Dr. Furman has just gone through some of the background on PI3 kinase inhibitors. In short, the PI3K are a family of lipid kinases that, upon activation, lead to a cascade of signaling events mediated through AKT that are important in cancer. They include effects on cell differentiation, migration, activation, proliferation, and survival. Now, as Dr. Furman has also mentioned, there are 4 different isoforms. The delta and gamma isoforms are important in hematologic malignancies as their expression is limited to cells of hematopoietic origin. IPI 145 is a potent oral dual both delta and gamma inhibitor, and it's currently in a phase 1 trial for patients with a broad array of hematologic malignancies. This morning I'm going to detail our experience in this phase 1 trial and for patients with chronic lymphocytic leukemia. But I should note there has been broad activity seen in other lymphoid malignancies. This is the schema of the trials. Essentially, patients were treated with 8 milligrams BID up to 100 milligrams POBID. The maximum tolerated dose was 75 milligrams. There were 3 different cohorts of patients that were part of this CLL experience. They include 28 patients treated at 25 milligrams or BID or less, 24 patients treated at 75 milligrams BID, which was the MTD, as well as more recently we've accrued 15 patients that were treatment naive. Now, the relapse refractory, the 52 patients that were relapsed or refractory, this included 61% of these patients that had it was less than 6 months from their prior therapy, and importantly, more than 50% of these patients had either a 17p deletion or a p53 mutation. In the treatment-naive cohort, in order to get onto this cohort, the patients had to have either a 17p deletion or p53 mutation, or they had to be greater than age 65. During our dose escalation phase of the trial, there were restrictions on entry according to cytopenias, but once we got to the expansion cohort, these restrictions were lifted, and in fact, more than 40% of the patients had grade 3 or greater cytopenias at baseline. This is the disposition of the patients that are on the trial. As you can see, the median follow-up of patients, the median time on therapy for the treatment-naive cohort is short, as they just recently entered, and was 2.7 months. The median time on treatment for the relapse and refractory patients was a little bit more than 5 months. 50% of the patients in the relapsed refractory subsets remain on therapy. Half have discontinued treatment for the leading causes were either adverse events or disease progression. This is the waterfall plot of the nodal responses in patients that were treated on this trial. I'm going to just walk you through this in a second because it's a little bit complicated. The orange or yellow bars are patients that were treated at 25 milligrams or less, which is the dose that we were going forward in phase 3 trials, in phase 2 and phase 3 trials. The blue is at the MTD, 75 milligrams. The circles at the top are patients who had the deleterious 17p deletion or p53 mutation. I would note that we've had started to enter patients who have had BTK failure, so there's one patient on this trial that represented by the diamond in this analysis who had failed prior BTK therapy. So as you can see, there was a fairly overwhelming nodal response. 98% of the patients, or 42 of the 43 analyzed here, of patients had a reduction in adenopathy by CT scan, and 89% of these patients treated at the 25 milligram BID dose had a nodal response of greater than 50%. And then treatment-naive patients, again, the data is a little bit immature at this time. There were responses. There were two patients with p53 mutations did have a nodal response with greater than 50% reduction in their tumor. This is the overall response and complete remission rate as determined by the IWCLL. As you can see in the overall cohort of patients, there was in the relapse refractory patients, there was a 47% overall response rate by the IWCLL. We were pleased that we actually saw one patient who achieved a complete remission, which was notable in this refractory patient population. It did not seem like there was a huge difference between the different dose levels, so the dose level is roughly the same at the 25 versus higher dose of 75 milligrams BID, and indeed the responses was also seen in patients with the 17p deletion or p53 mutation at roughly the same rate that was seen in the cohort at large. This is a snapshot of the AE profile of the patients treated on this. I would start out by saying the vast majority of adverse events are asymptomatic. They've been reversible. This details the AEs greater than grade 3 seen by all causality in greater than 5% of patients. And at the 25 milligram BID cohort, which is what we're going forward in the phase 3 trials. You can see that the side effect profile is consistent with what we've seen with other PI3 kinase inhibitors. There's a low incidence of ALT, grade 3 or grade 4 ALT, AST elevation. The vast majority of patients who have this issue can have the drug held and be restarted at either the same or lower dose. The cytopenias, there is an incidence of cytopenias, I think, reflecting the underlying patient population. If you will recall, greater than 40% of the patients that entered onto the CLL in this trial had, in the expansion cohorts, had baseline grade 3 or 4 cytopenias. So in summary, IPI-145 has an overall response rate of 48%, including one complete remission at doses of 25 milligrams or less. It was highly efficacious, as has been seen with an 89% nodal response rate, and we were pleased to see there were similar activities regardless of whether there was 17p deletion or p53 mutation. The safety profile is consistent with what we've seen with other PI3 kinase inhibitors. Most of these AEs were of low grade and all reversible. The hematologic AEs were generally transient. So early on in the study, we held drug, but now we know that we can continue patients on with neutropenia, and these neutropenia will resolve. There has been there's a decreased incidence of immunotransferase increases in the patients with CLL versus lymphoma. There's a higher incidence of neutropenia in the patients with CLL. So we believe this is emerging data that supports the continued development of 145 in patients with CLL, lymphoma, and other hematologic malignancies. And I want to just acknowledge my many co-investigators and, of course, the families and patients who participated in this trial.
Thank you, Dr.